My name's Kate Tredgett and I'm a consultant in palliative medicine working in Cheltenham General Hospital. I've been a palliative medicine consultant for more than 5 years, previously working in Swindon in the hospice and the hospital there. For me, it's about doing something that feels like it's made a tangible difference. And in my role, there's two sort of key elements. One is about providing direct care to patients and those who are important to them. And so it would be about a really successful interaction where we were able to identify the needs and respond to those in a timely way and in a really useful and helpful way. The other thing which my job involves is about influencing other clinicians to provide good palliative care and care to patients at the end of their lives. So, for example, teaching medical students or other doctors, I find hugely rewarding, particularly when you sort of get quite a sparky conversation and people feel able to share their experiences and explore how they can deliver better care. One thing that gives me real satisfaction is when you're just walking down the corridor and you bump into somebody else from one of the clinical teams and they ask you a question or ask you to support their team in changing something or delivering something differently. I think difficult days are days when you witness an imbalance of demand and the resource to respond to that demand. So it might be about just having a lot of people to see, so not feeling like you're giving them the time that they need. It might be not being able to access another particular service in a timely way. It may be that the hospital is under a huge amount of demand and pressure, and so everybody's working at a pace, and that can make things difficult. And I think even if your own team has got sort of all the people that it needs, it is still going to be impacted by other teams, perhaps being under-resourced for whatever reason, and that has a knock-on effect to the sort of care and support that you're delivering. I think in the specialty in which I work, because we would acknowledge that as intrinsic, that patients' priorities and preferences were key, that communication was incredibly important, and because we would acknowledge that people are more complex than the disease process, I think it's easier than in areas where it's very much the focus is on identifying a physical abnormality and treating and moving on. But even then, I think there's just something about a bit of time. It doesn't have to be ridiculous amounts of time, but actually, even just communicating to somebody that you have time, even if at the back of your head you're thinking that you don't, I think can be so important. That people feel acknowledged and heard, and often that's therapeutic in itself, and often there doesn't need to be another action from that. I would have a chair by every patient's bed for the clinician to sit on, and within the culture it would be ingrained that you interact with the patient at the level that they're at, unless clearly the activity requires you to be, you can't make someone's bed sitting down, can you? But I think sitting down with somebody conveys time. Doesn't need to be a lot of time, but it conveys that you're prepared to invest a little bit of time, and it does something about the power relationship that I think is often perceived, and I think can be unhelpful if you are sort of trying to address the human elements.
And are there chairs around?
You have to look for a chair. There's always a patient's chair, but that's usually covered in, you know, clothes and snacks and everything. So you have to go and find a chair. But I struggle as to how you can have an empowering conversation with somebody standing over them at the end of their bed. But I think some of that's a survival tactic to be able to keep moving and to cover the amount of work that needs to be done in a day. So I don't think it's about not wanting to engage. I think it's about not being able to because of conflicting pressures.